Hello, hello. Welcome to the transportation webinar focusing on substance use recovery, and I'm excited you're joining us. We're just going to take a few seconds as we get started. Super excited. My name is Valerie Loeffler. We've got music on as we all get started, just kind of chilling. So welcome everybody to our webinar this afternoon. While we are getting started, if you are just joining us, would love for you to enter an introduction in the chat. Let us know where you are joining from. If you have not used StreamYard before, it's kind of down here in the far right corner. Go ahead and tell us where you're from, where you're joining, what role in your organization, and just for fun, what is in one word, what does mobility mean to you? So go ahead and say hello in the chat. Let us know where you're coming from, your role, your organization, and in one word, what does mobility mean to you? I know we're only 1 minute in and going between meetings as we're getting started. It's like one meeting, 10 to the next. You're maybe enjoying lunch, grabbing a fresh cup of coffee. We're so excited that you're joining us here today. Hi, Erin. Thank you so much for joining. We're so excited that you're here. Hello, Melody. Hello. Austin, Texas, Northern Illinois. Greg, Mass Transit District, possibility. Ooh. Connection is what Erin is, absolutely. Ability is healthcare, absolutely. If you are just joining us, thank you so much, everybody, for attending our webinar today. We're just getting started, giving folks a few minutes to get on. Gianna, welcome. Oh my gosh, you are like the fairy godmother of this project. Thank you so much for joining us. Yes, 211, glad to have you here. Hello. We are so excited as we get started. Hello, Jack. We're so excited. Thank you so much. Brian, welcome. Northwest Illinois, training manager, equity. Absolutely. Jessica, welcome. Another Illinois participant. That's amazing. Teresa, hello. So excited. Welcome. Thank you so much, everybody who has joined us. Brian, Sadie, Jessica, Mikhail. Absolutely. So excited that you are here. Welcome. We are just giving folks a few minutes as we get started. Everybody's getting their coffee. Joshua, hello. Welcome. Thank you so much, everybody, for sharing information about where you're at, where you're coming from. Kim, hello. Oh my gosh. Hello, Kim, West Ohio. Oh my gosh. Kim and I go way back. So excited, Kim, that you're here. You're able to join. All right. Ashley, hello, Ashley, one of our board members. Thank you so much for coming, Ashley. Yay. All right. We're going to give folks maybe one more minute. All right. Tracy, hello. Tracy from Theta Care in Wisconsin. Yay. All right. Got some partners on here, got some board members, got some friends, got some new friends. Super excited as we get started. All right. Well, we are going to kick this party off here. All right. Let me get this going here. I know we've got some tunes going in the background. We will say goodbye to those, and we are going to get started. All right. And Melody in the background, I think Teresa needs to join through a different link. So can you reach out and have her join through the other link while we get started? All right, so let me just shift this here into presentation mode. Thank you again, everybody. We are so excited that you've taken time out of your afternoon to be here to learn. Today, we are going to kind of go through some kind of how did we get here? What was the origin? A little bit of opening remarks. And then Teresa is going to join us and talk about the challenge for SUD, OUD, and the role of transportation. Many of y'all on here know this well. Some of y'all may have not heard about this yet or have a good idea, but she's really going to bring that home. We're going to talk about the transportation prescription and the overview, talk about some partner perspectives. And we're going to have two of our clinical partners from United Connections Counseling and Coastal Plains Integrated Health. They're going to join us and talk about this program. And then we're going to talk about evaluations and outcomes, what's next. And then we're going to leave lots of time for Q&A. So if you have questions, go ahead and get those in the chat. Go ahead and post them just when you think about them. Don't have to wait till the end. And I wanted to bring up, so one of the things that a lot of communities know and experience is the barriers of transportation. And it comes up over and over and over and over and over again. And you're like, when is it going to change? What can we do to address this barrier? And I show this report cover from 1980. So when Feonix started working in the Coastal Bend, Judy Telge, who was the Coastal Bend Center for Independent Living director at that time, came to us and she's like, Valerie, you've got to see this. This has been literally, the transportation challenges have been documented in the Coastal Bend going back to 1980. This was written on typewriter, staple bound, and handwritten, drawn cover art. And in the 1980 Regional Conference on Transportation and the Transportation Survey, which today this is called the Human Services Coordinated Transportation Plan, and the FTA requires it be done every, I think, 7 years or 5 years. The same challenges that we saw when we got started in 2018 were the same ones from 1980. That is a long time to like, okay, yep, we still need rides in rural communities. Yep, it's still, the cost is insurmountable. How do we break this down? So today we're going to talk about the transportation prescription and how we were fortunate enough to do that and share our feedback. Before we dig into the details, I do want to share and make sure that we highlight that this project that we're going to be talking about today was funded by the Federal Office of Rural Health Policy, Health Resources Service Administration, and the U.S. Department of Health and Human Services. Everything that we're going to talk about is Feonix and our partners and our authors is not intended to be an endorsement by any of those agencies. So just always like to make sure we are including our disclosures. All right, so today, as I said, my name is, if you do not know me, thank you so much for joining. I'm Executive Director and founder of Feonix Mobility Rising. First up, you're going to hear from Teresa Loomis. She is the project director for the JBS International and is brilliant, amazing, so excited that you'll hear from her. And then Amy Pina, the clinical director for Coastal Plains Integrated Health, and Belinda Morin, the community health and wellness advocate for United Connections Counseling. They will be on stage and you will have a chance to hear them talk about their perspectives and feedback in using the program, as well as we're going to hear from Kathleen Spangler from Unite Us. She's a senior customer success manager. She is amazing. We've had the opportunity to work with Kathleen for a number of years on this project and are so excited to share these learnings. So without further ado, we are going to kick it off. Feonix's vision, for anybody who is not familiar with that, is mobility solutions for the health and well-being of every person in every community. And we mean that. So many times the work that we do in collaboration is really around healthcare, food access, employment, really looking at all social determinants of health. Sometimes we're supporting by providing a ride. Sometimes we're supporting by helping understand Medicaid regulations or Medicaid framework. Sometimes we're supporting by explaining what a van pool is and how we can work together. So Feonix our vision is to make sure everybody can get where they need to go to be healthy. Just a little bit of backstory. So Feonix and the Coastal Bend actually started literally months after the organization was formed in 2018. I know Jana Lineout's on the line. Jana Shu is on the line. Jana was a huge part of the collaboration and the partnership when we first got started with 211, the Coastal Bend Center for Independent Living, North Central, or the Coastal Bend Council of Governments. We came together and said, what are some of the challenges and how can we address some of the things that we documented all the way back in 2018? How can we kind of put a path forward for a plan for success? So in 2018, with the National Aging Disability Transportation Center, we got started and started planning and putting time into what would success look like. And then we had the great fortune in 2020 to have Centene Corporation and Superior Health Plan and Toyota join us. And during the pandemic, we actually launched a service called Feonix Wellness, and we delivered prescriptions, food boxes, and provided rides. In 2022, we were fortunate to receive funding from the Community Care Corps. We added volunteer drivers to the mix. And then in 2022, we were so fortunate to receive funding from HRSA to really dig into addressing those transportation barriers as it relates to SUD, OUD support with an emphasis on psychostimulants. And so over the course of these years, have really had the opportunity to learn from the community, to understand the barriers and the challenges that were experienced, and really dig into what would success look like and delivering that intervention. And today we'll also talk about the ROI. And so when we first got started, and this is a screenshot right of our proposal to HRSA, was that we showed that the data showed that 1.8 of the population, just in general, said they were needing but not receiving treatment at a specialty facility for illicit drug use in the past year. And then when you really focus that, instead of illicit treatment, say it's substance abuse, that increased to 5% or 4.71, which is a pretty high percentage of the population, broadly speaking, when you think about it. And so we said, what can we do? And the data, when you see the trip utilization and where folks were going, clearly showed that this was a need. And so this will come back to it. But when we were talking about what are the barriers, when you did our research, this became very clear. And so in our proposal, Coastal Plains Integrated Health, Community Action Corporation of South Texas, and United Connections Counseling came together with Feonix to really say, what would it look like if we broke down barriers in access to care in rural communities in the Coastal Plains? And so today you're going to learn a lot about that. So with that, I'm going to turn it over to Teresa. And Teresa, go ahead and introduce yourself. And I'm going to go ahead and just tell me next slide.
All right. Well, I just want to make sure you can hear me.
Yep.
Okay. Wonderful. Good. Wonderful. So hello, everyone. I'm happy to be here. I'm Teresa Lemus. I am a technical expert lead with JBS International. We provide the training and technical assistance for the Rural Community Opioid Response Program. And I feel very fortunate to have been assigned this project that Feonix folks to work with in their grant proposal and their grant award over the course of 3 years to really look at the issue of reducing opioid overdose. And one way to do that, and one brilliant way to do that, is to look at needs that are associated with getting to care, which obviously one of those is transportation. So that's a little bit about me, and you can go ahead and go to the next slide. So I'm just going to talk a little bit about the disproportionate need and how that's related to disconnected access. And I won't belabor too much, but just some points. I mean, we know that buprenorphine, methadone, and other FDA-approved medications are highly effective for treating substance use disorder, including opioid use disorder. But you have to be able to get it. You have to be able to access it in order to use that to address this health need. There's a 2025 study that looked at the fact that 33% of rural residents live in areas where there's relatively no access. And some of the reasons for that are obviously just the numbers. You need to have the population there. Unfortunately, in many rural areas, if not most, we do have the population there with the need. But then there are things like stigma. So if you walk into, this certain office in your small community, does everyone know exactly what you're doing, and how does that impact your job and your kids at school and those kinds of things? So those are some of the issues that we hear about. There's also the issue that even though we have seen a growth in the number of prescribers for medications for opioid use and other substance use disorder, there's still all the barriers that I just talked about, including having providers, sort of position themselves or be available in rural areas. And telehealth has helped somewhat, but there's still always a need to have that face-to-face time and assessment and some of the continuing follow-up. And depending on how the medication is being prescribed and administered, there's a need to, sometimes be in an office with the provider. And we know that this is particularly impacting vulnerable populations. The slide lists justice involved individuals. They are released from detention, and if they don't have, and many times that's at 2:00 in the morning, and we learn these things from many of our providers. They say, people are let out at 2:00 in the morning, 3:00 in the morning, with no transportation, no basic needs, and so the chances of them running across someone who has an illicit substance versus getting to their appointment to start MAT care is it's just not a fair shot. So we know that those are some of the things that we need to be looking at. Next slide. You can go to the next slide. So there we go. I mean, without a way to get somewhere that is not just the ride, but also having it be consistent, having it be reliable, having it be safe is very important. Consistent access so that people can get to their appointments for medication, so they can get to one-on-one and group therapy and other essential services. We just talked about the justice involved population, individuals who are involved with child welfare or other types of social services. They have responsibilities to get to appointments and be in court or be somewhere to talk to their probation officer. And if they cannot get there, and they cannot get to the services to provide their medication, then they're seen as incompliant. And what do we do with individuals who are, uncompliant? We say, gosh, they don't have the drive, they don't have the will to do this, and they're just resistant to treatment. And that's usually the way that they're sort of put in that bucket. So, a little bit about the research on this is that there are a lot of Medicaid beneficiaries that miss or delay healthcare because of transportation issues. We know that the lack of transportation, non-emergency medical transportation leads to delays, and poorer health comes for everything, not just substance use disorder, but every health outcome that we could think about. And so it's something that we really need to be thinking about, especially with medication-assisted treatment, because there needs to be, a period of assessment. There needs to be a period of making sure that we get individuals on the right dose and that they have a consistent schedule, that they can be maintained and monitored on the medication for it to work, which supports recovery. Next slide. So we have a broken map because it's such a fragmented system in such, wide, vast areas in rural America. Again, you can look at the information from SAMHSA, the Substance Use Mental Health Services Administration. They have a treatment locator that sort of shows, where the the licensed treatment providers are across the country. And if you take a look at that, you'll see that there's a lot of disparity. So there's just key challenges when we think about accessing MAT and any type of treatment for substance use disorder, and I would argue even mental health treatment in rural areas. There's limited provider availability. We talked about that. The transportation, not having transportation to get from a rural area to a treatment facility that has the services that you need is imperative. This is treatment just like any other treatment. If I need an antibiotic for an infection, I need an antibiotic for an infection. If I need buprenorphine for my opioid use disorder, that's what I need. And so we have to look at that and think about if we can't get individuals to the treatment that they need, then it's likely that they're not going to be successful. I talked a little bit about stigma. And we know that individuals who live in rural America who do not have services available in their community and don't have a way to get to those services, either they might find a way and then not be able to eat or feed their family or pay their rent because they're getting a ride from someone. Sometimes that can be very expensive and also unsafe. So those are things that we want to look at, and just all the other appointments that they have that keep them in compliance with all of the treatment that they need. Next slide. We know that Medicaid has some assurance of transportation guidelines. I mean, there's a statutory requirement for state plans to guarantee access to care, but we know that that's not always carried out or implemented consistently. And what I find, even in small communities, that if you're dealing with social workers or other folks that are working in the social services system, sometimes it's not that they don't want to, they just don't know about how to access some of these services. And that's something I think that we need to work on across the board. But between 2018 and 2021, 3 to 4 million Medicaid beneficiaries were able to use non-emergency medical transportation to access their care and SUD treatment. But that's just a drop in the bucket. And again, I think we have to work at this from different levels so that our court systems, our social services, our medical providers, have some resources to know that this is a benefit. So even if the patient doesn't know it, that we have some way to connect individuals to this service. Next slide. And I think this is my last slide. When Valerie and her team started talking about transportation, prescription, and mobility as medicine, I thought that is just absolutely perfect. I live in Reno, Nevada, and that's where I work from, but I also work in rural areas in Nevada. Nevada is not just rural, but we're frontier. And so I know, because I work with individuals who live 3 hours away, and 3 hours is just one way is the distance they have to travel to get to a place where certain services are available. So it's not just a logistical barrier, it's a clinical intervention. We wouldn't expect that if someone needed to, have treatment for cancer or some other medical issue, it's unlikely that we would say, well, that's too bad. If you can't get there, we'll just have to, have you go talk to somebody in this office and see if that works. We need to really think about this as transportation and mobility as medicine. And so if by doing that, we not only reduce recidivism, we improve treatment and recovery trajectories, and we have higher involvement and retention in care. And that really adds up to a lot when you're talking about individuals that have families, that need to hold jobs, that contribute to society, that want to do all those things and are just not able to juggle all of the challenges that they have. So in closing, transportation access must be treated as seriously as medication access. We have medications. If you don't have access, you don't have treatment.
Teresa, thank you so much for sharing that wisdom and all of your support over the 3 years of the grant. It's just been a pleasure and a joy to learn from you and to work together on this program. So thank you.
Thank you.
All right. So jumping forward here, the transportation prescription, what is it? What does this look like? How did it work? What did we learn? Let's get started. So just to recap, patient missing life-saving SUD treatments every day because they cannot get a ride. We know this happens. Many of you who are on the call know this well. Relapse is more likely when patients can't get to treatment, MAT treatment, or counseling. Health workers and families struggle to coordinate rides to specialty care. Lack of transportation can lead to emergency room visits or even jail. Missed appointments erode hope and progress, which increases stress, which decreases hopefulness, and families are separated when parents can't attend court or supervised visits. One of the stories of when this program actually first got started was around a young mom who the clinic director at that time, Russell's with Coastal Plains Integrated Health, shared. He was in an emergency room, and this mother had missed a ride to go to her daughter's court appointment to regain custody. And it was her last chance, or the child was going to end up back in foster care and she would lose her rights as a mother. And she was working so hard with Russell to get to treatment, to get to counseling, to get what she needed to do. And after that point, she had, overdosed. She was in the ER. She had major health issues because the despair of losing her ability to be a mother was really traumatic, as any mother would understand, or any parent would understand what that is like. And she just gave up hope at that point. And so all of this is interconnected. Not one of these pieces operates alone. And we said, how can we break this down? So Teresa talked a little bit about NEMT. Many times with the NEMT benefit, you can get to the hospital, you can get to most of the behavioral health. A lot of times that may be considered other types of services that sometimes aren't covered under NEMT, depending on the state that you're in. And we wanted to say, let's look at the whole person. Where does somebody need to go to recover and be well? And when we talked about the transportation prescription, it's not the limitation to only get to the doctor. We had a lot of folks who needed to get to the grocery store. We had folks who needed to get to a job interview. We had folks who needed to get to court and to follow up appointments with probation officers. And so the transportation prescription looks at the whole person. And we really kind of changed the framework. If you think about how food stamps used to work, or WIC benefits used to work in the 90s, you were able to get certain types of milk and certain types of cheese, and there was these little tiny stamps that you would tear off at the checking counter or at the grocery store check counter. And sometimes it was very stigmatizing, it was very humanizing. And what happens if you're lactose intolerant? How many mothers now realize that lactose intolerance contributed to a lot of their babies' health issues? My brother was one of those where, we didn't know he had a milk allergy until, he was in his 20s, right? So all of those things, right? And so when we think about food insecurity, we now can go to the grocery store. Your benefits are whatever, generally speaking, is on the shelves. You decide whether you want oat milk or regular milk or potato bread or wheat bread. You're the decider of those decisions. Whereas in transportation right now, we're still limiting folks to milk and cheese and maybe some bread, right? Whereas the transportation prescription is the future in our hopes and minds of how we can look at transportation insecurity. We don't need to dictate who you can get to take you to what appointments. Let's just help you solve that transportation challenge. And so when we rolled this out, how this worked is the patient with the transportation need is identified. This can be done by the social worker, the case manager, the care coordinator, the physician, whoever is in the driver's seat designated by the healthcare partner makes the decision. so that social worker can write the transportation prescription, if you will. Then the healthcare partner would put the referral into Unite Us, and you'll hear from Kathleen and see her technology here in a little bit. But that went into Unite Us as a referral. Then we would accept the referral in Unite Us. The healthcare partner created the request for the mobility wallet. We then contacted the patient, scheduled the rides, and then we performed the trip. So this is kind of how that all worked in the ecosystem when we first got started. And so when you're thinking about, well, what does that transportation prescription form look like? I'm a pretty visual learner. And it was just this, where the patient name, their contact information, what type of transportation they were needing, how many trip legs. So that social worker, case manager, care coordinator could decide, does this person need four appointment trips or 2 appointment trips or 10 appointment trips? That was decided by the individual writing the prescription, similar to how many Lexapro or how many buprenorphine, that prescription designation was made by the individual completing the form, and they shared what the appointment was or what the trip support was supposed to be around. So this was kind of where we started with the transportation prescription. And so when we saw what the needs were, access to specialty care was 45% of all of the rides that we took. And that does not surprise us, because when we wrote our proposal in feedback and clinical and the data, this was the issue. You can get to local most of the time, but the specialty care was always without of reach, especially in rural areas, right? I need to get 40 miles into town. I need to get 150 miles to the closest inpatient treatment. I need to get long distances. So we knew this was the barrier, and we addressed it with this program. So just super excited to be like, here's what the data said. This was the intervention that was deployed. And by gosh, it worked. Woohoo! So specialty care was our number one. Secondary was primary care. And then you saw court appointments, mental health appointments for doctor or case management, peer support, other case management, not related to mental health, but other case management related needs, and then SDOH. Some folks needed to get to food access, some folks needed job access, some folks needed help getting to the security office to get their housing application filled out, whatever that is. But this was kind of where we saw the need and how that kind of manifested when the trips were provided. And one of the other things that was really unique about this program when we rolled it out was also understanding the safety needs. We worked really hard to make sure our drivers were prepared and trained, that we had tracking information about where the vehicle was at, where the driver was at, and we had all of that information because we knew when you're sending in folks out in rural areas, and many of y'all on the line are here, right? And rural, right? And so if somebody's out in an area where there's no cell service or there's no cell signal, and you run off the road, or you have a flat tire, or you have an issue that might come up in the vehicle, you want there to be documented evidence of what happened if there was some incident in the vehicle. And so we have a great partnership with Samsara. And so we have AI detection on the drivers. So if the driver is tired or whatever, but also if the patient in the back seat says something or does something that is inappropriate or whatever, all of that is on camera and recorded so we can keep everybody safe. That was one of the biggest needs, because we know cell signal, being able to get a hold of somebody, that knowing their safety and somebody is watching and somebody's able to support me is huge. In terms of ridership, we provided during the course of this grant over 3,000 trips. We supported over 500 patients. The average trip distance was 20 miles. That once we kind of got about 6-7 months into the project, that really stabilized. But what was very interesting is often we would have to drive 30 to 40 miles, what they call deadhead, where there's nobody in the vehicle. So we might drive 35 miles to pick somebody up and take them 20. And that's what makes rural transportation so expensive. So our average cost per trip was $52. So that is not a small investment when you look at $104 to get somebody to and from an appointment. And that's why this ROI data is such a valuable component of this project and understanding. We also provided a lot of, not a lot, but a decent percent of really long trips, in particular to inpatient treatment services. Sometimes the closest bed was 150 miles away. In some cases, we would take people over 200 miles to get to the care and the treatment and the support that they needed. Sometimes we were taking folks to do visitation appointments with their children, and the closest foster home was over 100 miles away. And so in order to make that work and in order to support families and get folks where they need to go, we said, you tell us what's the distance. So predominantly we stayed in the Coastal Bend area, but in some cases we were in San Antonio, Victoria, Laredo, to make those clinical interventions successful to help get folks where they needed to go to be well. All right, well, enough from me. We are going to bring up two of our partners who really were invaluable in really thinking about what does success look like? And I can sit here all day long and say, yay, it's great, we solved, we did, so on and so forth. But Amy and Belinda are going to join us here on stage. And I'm going to ask them some questions. And if you have questions for Amy and Belinda, please put them into the chat and we will answer them at the end. So Amy and Belinda, thank you so much for joining us. I'm so excited that you're here today to talk about the program. Before we get started, could you just maybe introduce yourself, give a little bit of background clinically, kind of how did you get to where you are? And Amy, do you want to kick us off?
Sure. Hi, I'm Amy Pina, and I am the clinic director here in Taft, Texas, which is a very rural community. As a matter of fact, if you walk out our front door, all you're going to see are cotton fields currently. I've been in mental health for 27 years, and this is where my heart is. And once we partnered with Feonix Mobility, I've learned a lot about transportation, and this has been such an amazing opportunity for us and for the individuals that we serve.
Thank you so much, Amy. Belinda.
So I'm Belinda Morin, and I contract with different agencies throughout the Coastal Bend. So I see Jana's online with us, Coastal Bend Wellness Foundation. So I do contract with United Connections Counseling. I contract with Alzheimer's Association and also with Connections Individual and Family Services. So you all see my name probably for Coastal Bend quite often. I've been working nonprofit since 2007. One of the things that became really important to me few years back was advocating for rural health, making sure that we are able to, reduce those barriers that people in rural communities face. One of the things about this project that I really enjoyed was that I thought that I knew a lot, and it was every time I talked to a different client or to a different community partner, I learned more, and I learned about the gaps, and then also it's really got my mind thinking about what ways that we can close those gaps. So I really enjoyed these 3 years with everybody. So thank you for the opportunity.
Absolutely. Thank you, Belinda. So our first question is, can you tell a little bit about, in particular, what type of transportation barriers you saw for your patients or your clients kind of before the program began? Belinda, you want to take that first, or Amy, you want to go first?
I'll go first, Amy, this time. Okay, we'll go back and forth. Okay, so our service area served mostly rural, and although United Connections Counseling does serve 12 counties, the majority of the rides were in Jim Wells and Duval County. And so when I'm talking about rural communities, I'm talking about tiny towns, farms, ranches. And so the closest minor city to us would be Alice, and that's where people go for prescription pickup, grocery pickups, social engagement, leisure sometimes. I grew up in one of those small communities, and the population was 150 when I lived there, and right now it's probably 50. And so for us, if we had to come to Alice to get our groceries, it's an 80-mile round trip. And so for those that are lacking transportation in those areas, people usually end up having to catch a ride if they need to come to the doctor, pick up groceries. Now, we do have Real in the area, which is it's a great asset to these communities. Thing is that folks are still they're uneasy about using the service sometimes. They're intimidated by the process. They're intimidated by the scheduling process. They're intimidated by the waiting time. And sometimes they're just intimidated about the ride in general because of the trip, because they don't know what's going to happen when they leave the house by the time they get back. So yeah, the uncertainty, that's one of the things that holds them back. And I think this project, knowing that they were going to be able to schedule the rides that they needed, and that they would be able to come and go at the times that they needed to come and go, I think that was one of the big buy-ins for us, for UCC.
Absolutely. Thank you for that, Belinda. Amy, how about you?
Well, here at Coastal Plains, we serve a 9-county area, and we surround Nueces County, which is where so many of the resources are. And depending on where you live at, you're looking at 40 miles. And then for inpatient substance abuse treatment, you're looking at possibly 130, 150. And if the transportation's not there, you lose that bed, and you lose that moment, that window where an individual is ready to get that treatment. So the barriers are, like Teresa stated earlier, in regards to the stigma related to where these individuals are getting dropped off at. If you live in a small town, or if you're from a small town, you'll know that you're either related to everyone or you know them. And so that did affect individuals receiving treatment. And one of the buy-ins for this program was that it is person-centered. So the individual did not have that high level of anxiety in regards to utilizing that transportation and being concerned about where they were dropping off, or if it was a probation or a parole appointment, things like that. They had that easy access. So that was a huge piece of it. And when it comes to transportation, some individuals put themselves in dangerous situations, or they might stress a relationship out with a family member because they're always asking for rides. And when I'm talking about putting yourself in a dangerous situation, I had an individual that was riding a mobilized chair to a primary care appointment on a highway that is a 75-mile-per-hour highway. That is one of the best examples that I have of this, rural area, and how determined they are to get somewhere and the risks that they will take.
Yeah, that goes to a whole new level of pedestrian injury, pedestrian access. And I know I've seen multiple times, whether it be Nebraska, Texas, Wisconsin, Michigan, Tennessee, folks are, they're putting a electric wheelchair or a manual wheelchair in traffic because there's no sidewalks, and they still need to get to groceries. They still need to get to healthcare. So absolutely. And so I appreciate you sharing that. Amy, do you want to tell a story, or can you share a specific story that kind of captures kind of what was that experience like for the transportation prescription, maybe for one of the patients?
Well, with the population that we serve, I had an individual, like, through the pandemic, did not leave his apartment. He would have items delivered, usually by family members that were exhausted because they don't live in the area that he lives in, but they were trying to have him meet his needs, but he would not come out of his apartment. His first transport or chance out of his apartment was in a Feonix vehicle. It was so amazing. And that when he finally walked through our doors, it was like we never met. It was just so amazing. It was so amazing. But that was his first ride. And I think that that's a huge part of it, because I really, truly feel that if he had to get on a bus, he would not have done it. If there was transportation with other individuals in the vehicle at that time, he would not have done it. this was a person-centered ride for him, which we, through a lot of encouragement, finally he built up the courage to get in a vehicle, and it happened to be a Feonix vehicle at that time. So
awesome. Thank you so much for sharing that. And I think the unique element of this program kind of coming and starting as kind of the pandemic hit full steam and communities were really kind of at that place where like, okay, how do we get patients back into the office? How do we meet people where they are at? I mean, when we first rolled this out during the pandemic, when we were delivering prescriptions, I see John Gertrude's on the, we had those little grabber mobile, like those things where you like pick up a sock if you can't get down. And like we were literally delivering prescriptions to folks like through the fence with like a grabber. And now to go from that, like 2020, 2021, we got started in 2022 where we're like, hey, join us, become a part of the community. We need to see you as a healthcare provider in person versus just over the phone. And so these trips really took that like next step of making folks feel safe from a healthcare perspective as well as just a social perspective. Absolutely. Belinda, how about you? Is there a story that comes to mind?
Yes. So Monica S. She was from a very conservative family, and so there was family strife. So she left the house fairly young, and her substance use started right after that. And so as she started this bumpy ride of substance use disorder, her parents were there for her at times, but they weren't there for her all the time. There's certain points there were, certain points they weren't. They had to take custody of her son. And I think it's always that grandparent fear that Children's Services is going to come in and take their grandchild. And so they always kind of kept Monica at arm's length. And so she started couch surfing, staying with dealers, and doing whatever she had to do to survive. Monica was in and out of jail a lot of times. She tried inpatient treatment several times. She tried NA. For Monica, the fourth time in inpatient treatment was the charm. When she came out, she was able to, through the project, she was able to make her probation meetings. She was able to keep her job, get rights to her job. Most importantly, she was able to get to her NA meetings and to her peer recovery meetings. And so the last time I talked to Monica, because she graduated from our program, she wasn't with us, but when I followed up with her, she was actually getting her stuff together because she wants to be a peer recovery coach. So I think that's really a success story. I do want to share, in all honesty and transparency, that the first ride with Monica was a bust. There was a miscommunication between myself and Senecor for the time that we were supposed to pick her up. And so they had scheduled for 6, and of course our cars didn't run after 6. So Monica ended up having to walk to the bus stop. But she was very understanding, and she was always very enthusiastic when she called about her other, whenever she had other appointments to get to, and she was always very grateful for the project, and just hearing that gratitude in her voice, it kind of makes it worth it when you hear clients expressing that to you. And then it also gives you a little sense of pride when you see that they're succeeding.
Yeah, absolutely. And I appreciate you sharing that, because it's one of those parts where innovation, when there's so many layers, and there's a dog that just walked in, so my apologies. I hope you are not hearing this. But yeah, this element of you're going to try stuff, and there's different pieces of, especially in transportation or healthcare in general, right? There's so many layers of communication that have to go right. And I think that everybody working together and being like, okay, we learned pivot. We learned pivot. We learned add a layer. We learned adjust was such a vital part of the partnership, that really that just consistent communication going, okay, that works. That did not work. Try this. and that's the piece of the conversation. So Amy, from your perspective, how did this workflow, you're covering 9 counties, and you had a lot of staff who were using this program and were able to write prescriptions. Can you share how that worked for you?
The ease of the process in regards to making the referral was a huge factor in our staff actually using this as a resource. So there was the ease of it, and there was the reliability of knowing that transport was going to happen. The Feonix mobility staff would contact the individual, and that was a huge part of it, because they didn't just have to assume that the transport was made or that it was scheduled. They knew it was because they made contact with them. So that was always a positive aspect of this. But the ease of the process, because when it comes to making referrals and the individuals actually using those referrals, is dependent on how easy it is to get that access. So that was the two huge factors, were the ease of the process and the reliability of the transportation.
Well, thank you for sharing that. We worked really hard, and I know it got better as the program got started, and even more to come.
I'd like to throw in there that because it was electronically sent over, that made it a lot easier also. And then you got the check mark to know that it was confirmed, and you didn't have to wonder about it. The other option that we've always had in the past was faxing, and we never really knew what was going on or if it was confirmed or made. So just that electronic mode was awesome.
Yeah, that two-way communication, or even for the patient, you can call in and order your Medicaid ride, but many times you don't know who's going to come pick you up. You just know I've requested a trip. You don't know which organization it's going to be. You don't know which driver it's going to be. You just know I called, and fingers crossed.
The individuals that we served were very appreciative of the drivers.
Mm-hmm. Absolutely. Belinda, how about for your team? I mean, working very distributed as well. What was the process look like? How did that integrate into kind of the daily workflow for your team?
Well, for us, at our agency, I controlled most of the processes. Found that it was easier, even though we're a very small organization, we do have a lot of clients. And so in order to build that relationship of security for the clients, I found that it was easier if they knew that they could call Belinda when they needed a ride, instead of Sam or Tracy or Belinda. It would just became easier after about 2 or 3 months, figuring out that, they depended on me, they counted on me, they were secure in the fact that if they called and asked for Belinda, that they were going to get that ride. So it was easy. That's what really worked for me, I felt. So I would get the referral from the counselors, from the referral specialist, putting into Unitas. They would do the prescription. And then I know that the driver would follow up with the client to let them know, but I would also follow up with them after the ride. After a couple of days, I would go through the list and kind of choose which riders I wanted to contact, shoot them an email, shoot them a text, and say like, hey, how did things go on Monday? Was the car comfortable? Was the ride comfortable? Like, how was the driver? Kind of, did you feel safe? Did you feel secure? That was important for us too. One of the things that really increased buy-in for us too was scheduling rides a month in advance. So after the riders had about 2 rides, they felt secure that they were going to be able to get to where they were going to go. And so scheduling those times, and then also having, when they came in, we would ask at intake, is transportation an issue for you? And then having our counselors ask every time they went in, are you going to need rides for our next appointment? Are you going to need rides for grocery pickup? Do you need a ride to pick up your child after school? And just so that way we kind of knew what was happening, and that we were able to schedule those ahead of time. That really helped. That was one of the learning things that we learned after about the second month, that I learned it was a lot easier. And I feel like that also helped the clients feel like they could schedule more appointments, because many of our clients are folks that are involved in probation, CPS, and so their focus is getting this done. But a lot of times they were ignoring their own personal health, and they weren't going to those medical appointments, gyno appointments, mammograms, all that kind of thing. So I think that eased up in their minds, knowing that, this transportation was available. And so then they started to do more self-care and wellness for themselves, which was really an important part for me, for the clients to walk away with. It's not just completing what we have to complete. It also has to deal with keeping ourselves well from when you leave UCC.
Yeah, absolutely. And I think you touched on a really important piece as well, when it's like the you have to add that question into the client intake workflow. Like, and we see that a lot of times when we work with new healthcare partners. It doesn't matter where at, it's like, okay, I have to ask one more question. And the clients or the patients aren't used to getting it, because it's like, what do you mean? Do I need transportation? What are you talking? What do you mean to get to here? Or oh, I could get help getting to groceries, or wait, I could get help getting to a job interview. Like, for real? Like, and that question happening every single time is also an important piece of that, because a lot of times it's like, okay, I'm just going to go through my checklist and I hit that, what do you want to call it? That muscle memory, that conversation memory. And so then having to add that in, I know at several different points we're like, hey, one agency or the other, we're like, we're not seeing a lot of rides. Is everything okay? Oh, let me send a reminder to the team to remember to ask. And then we'd see rides climb back up. And so it was one of those pieces where it was just like workflow. I remember working several years ago with a community partner in Missouri, and the CFO of the FQHC was literally like, I will buy you a steak dinner if you refer the most rides to this program. Because it was one of those things where you have to be like, oh, that's right, I forgot to ask you, right? Or at the front desk, they're checking out, hey, do you need help getting here? Like, all those conversations that right now you're not thinking about transportation, all of a sudden throwing that in there. Amy, Belinda, anything you want to add on that piece of the puzzle?
No, ma'am.
All right. Well, so Amy, when you think about, healthcare, community, and mobility, how working across these sectors has that shaped your experience?
I truly feel that when I come to appreciate all modes of transportation. Like, when I would see a bus, a city bus, I would be like, wow, look. I mean, everything transportation became a bigger, not fascination for me, but desire to make sure that, or learning that individuals' needs are being met. And then through recovery, transportation kind of basically equals recovery for our individuals. And I think, or I feel that, when you have easy access to a vehicle, you take that for granted. And when you're without, you might tend to fall back into a cycle of your old habits. So just like I was saying earlier, with the SUD treatment, inpatient SUD treatment being 130 miles away, if you don't have access to that, there's a high percentage or high chance that you're going to turn back into your old habits. Or if you don't have the ability to make that parole appointment, that SUD appointment, that substance abuse counseling, you're going to fall back into your old ways. So that was huge for us, is that, that guaranteed access to those treatments promoted the recovery.
That's amazing to hear. And thank you for sharing that, Amy. Belinda, from your perspective, what came? Yeah.
So for me, I learned a lot about transportation, like Amy said. And also was able to learn about a lot of programs that I didn't know about, resources that were available. We still do have a lot of work to do, though. Sometimes referrals still, and I just mean in general. I'm not just talking about UCC. I'm just talking about, in general, a lot of the, referrals, they still fall through the cracks, right? And sometimes I think we're pushing towards this technology, but we have to meet people where they are, right? And so in some of the communities that I'm talking about, for us, we wake up in the morning, we grab our smartphone, we grab our laptop, because we have access, right? And some of these communities, they don't have access to internet or to computers or to smartphones. And so sometimes just having to still deal with good old fashioned pen and paper, making phone calls, popping in to different agencies to find out what resources they offer. One of the things that I started doing was I started taking, which has helped a lot, is taking a volunteer with me when I go to health fairs and letting them man the table. And then I go vendor per vendor, grabbing business cards, giving my business cards, learning about what they offer, so that when I get back to the office, I know what resources I need to match with what client. And I don't think I would have been so motivated to do that if it hadn't been for this project. So
awesome.
Yes.
Well, thank you so much for sharing that, Belinda. And it really does take an ecosystem, right? Nobody lives in this vacuum where I only need access to mobility. All those social determinants of health, those referrals are still a huge need. Amy, were you going to say something? Did I interrupt you?
Well, I was just going to say that when I was talking about individuals taking transportation for granted, what I could do, I mean, I have access to a vehicle. I could drive over the bridge for anything that I need twice a day if I had to. However, a lot of our resources, they're not located in our rural areas. They are in what we call over the bridge in Corpus. And access to that would be the medication assisted treatment. That would be the substance abuse treatment. There's primary care. If you receive indigent care, you might actually have to go 130 miles for a specialized care. So I just wanted to throw that out there, because I don't know that if you're not familiar with the rural area, you really don't realize the barriers that exist in regards to transportation.
Yeah, absolutely. Growing up in a small town and graduating with a class of 16 can absolutely relate and appreciate. Well, Amy and Belinda, thank you so much for joining us during the webinar today. And for folks who are joining us, Amy and Belinda aren't going anywhere. They will be back up with us when we have the Q&A. So if you have questions, I see we've got a few already, but if you have questions for Amy and Belinda based upon their feedback or the other parts of the program you'd like their feedback on, go ahead and enter those in the chat. We would love for those questions and Amy and Belinda to join us. So Amy, Belinda, thank you so much for everything. Appreciate your support and collaboration. It was a dream working together on this program, and can't wait for more opportunities to come.
Thank you.
Thank you. All right. Well, now we're going to talk about the evaluation and outcomes. What was the ROI? And so to kick this off, I'm actually going to introduce Kathleen from Unite Us, and she is going to give a little bit of a sneak preview of how the Unite Us program worked and what the different elements came to life is how this works. And I know we have some team members. I know Tracy's on the line from Theta Care. They are just getting started with the Unite Us. So take it away, Kathleen. Excited to hear your feedback and how the program worked.
Well, thank you so much, Valerie, for having me participate in this a bit. And I've really enjoyed the conversation and hearing the stories, and really, putting some stories and some details into the work that we were able to do together in Coastal Bend. It was really a really innovative project, and we just love being a part of it. And and to broaden the conversation just a bit from transportation and substance use disorder, transportation is what we see across our networks is a barrier to getting all kinds of care, all kinds of social care, and physical and mental and behavioral health care. So Unite Us is, and you mentioned it a bit in your presentation, the referral technology that was sort of the technological mesh between the partners of this project, and referrals were for transportation were sent to you electronically that way, so that you could have a closed loop experience, which means that everyone had visibility into the acceptance of that referral, and then whether the person got their transportation need resolved and got the care they needed. And so that's what we do, or that's part of what we do at least, is building networks of all kinds of healthcare and social care providers to really work together and collaborate in that way. And what we see in our network, with regard to transportation specifically is, same story, different verse from what y'all were saying before, is that it's a huge need. As far, one good thing about having a technology platform is you get a lot of data, and you get to see, what needs are being presented, how well we're doing resolving certain needs by service type and transportation, both in our data and then just from what we hear and talking to coalitions we work with and partners we work with is a big need. And a barrier to getting other needs met. So it's the 9th across our network. I just did a little research for this, and it's the 9th most common need for referrals sent in our network. So it's right up there, and that's just the need presented for a referral that's actually a case created or a referral made in our network. That doesn't count the times that someone needs transportation and a referral's not put in there because maybe they just know, there may not be a transportation provider in that area. So we're not capturing that entire need, but even the ones that we're capturing, it's pretty high on the list of things that people need. And then conversely, the resources are scarce. So, food is also a high need in our network, but the good news is we have quite a few food resources. Transportation, not so much. There aren't that many organizations like Feonix specializing in transportation. And so that is, definitely an issue. If you look at, we're able to look in our networks and see the service types of the programs that our partners provide. And if you look at we have about 20 main service types, and transportation is 15 out of 20 as far as the programs on our network. And we would love to have more transportation resources. That's always something we're out on the lookout for. So that disparity between the need and the supply is pretty stark. And then just our partners report that transportation is a barrier for their clients and their patients. That is, I talk to a lot of groups and ask the question, where are the gaps? What are the challenges to getting people care, physical, mental, behavioral health, and social care? And I could count on one hand maybe the times that transportation wasn't mentioned in the first 2 minutes of that conversation. It always comes up, and one of the things that our partners in our network, they can say, like maybe they're not a transportation org per se, but they, let's say they provide something else like legal services or clothing or food. But one of the aspects of their program that they can report out in their partner profile is, do they provide transportation to themselves to get the services that they give? And some do. And that is often in the form of maybe, a voucher for a bus ride or something like that. It's rarely a ride, but, it could be in some circumstances. But, those organizations are limited in their capacity to do that. And if you're in a rural area, a bus pass may do you no good whatsoever. So, that's an issue as well. Organizations try their best to help people get to them, but a lot of them are doing their best just to provide their direct services and don't have anything left over to provide that transportation. So if you'll go to the next slide. So the idea of closed loop referrals, I mentioned it a bit, and when Valerie was talking about how the referrals came into them, their partners find a transportation need and send it along. And then the last part of that is shown on this slide in the sort of the right-hand side there. These referrals are HIPAA compliant, so there's consent, all of that good stuff. But then there is the rest of the story, right? Did they get their need resolved? Did they get care? And of course, it's not limited to transportation. We have, like I said, 20 main types and I think 75 plus subtypes of services you can refer people for: food, healthcare, clothing, employment, all of that. And so when a referral is sent, you have visibility, well, first of all, to pick a good match for them by seeing good up-to-date program information, eligibility requirements, but then also getting that feedback of when that referrals accepted, the clients reached out to, helped in the usual processes of the recipient organization to get them help. Then they close that case, and then you have access to see, did they get their need resolved and what specific outcomes happened? What services they received? And so, as far as workflow, this is how you do it. I grabbed a few screenshots from my demonstration version of the platform. So it's all fake data, fake organizations, fake clients, but you basically tell the machine what you need for that client, and then you get to look in their geography for available resources for that service. And so it's just clicking a box there, and then in the next slide you'll see that you get to pull up and really see detailed information about resources that are kept up to date by our partners themselves. They own that profile, and we ask them as part of our network standards, if things change, if eligibility requirement change, that sort of thing, that you keep that up to date, so you're seeing fresh information and can pick a good match. So that's what that would look like. And then you have a dashboard that would show the status of all the referrals you've sent out, and you can watch on those. We ask our partners to act on referrals quickly and keep the traffic moving, and so you would see those as well. So then when they get accepted and get care, they're closed out. And then this is an example of one that was closed out. So the recipient organization could see this on the sending organization could see this on their end and see that, in this case, Jonah was sent over for food and got his need resolved. He was enrolled in food pantry services and got a healthy food box. So that's kind of the quick and dirty, look into it. And then, of course, we have data, Tableau-based dashboards that our partners have access to show de-identified aggregate data about who's being served in our network, or by them, that org specifically, or the whole network, or a specific geography. And in this pilot, we saw a couple of things. First of all, the age ranges, that it was the biggest age range was at 18 to 44, or the younger adult age range there. And then older adults, though, was quite a big slice. And when I say older adults, I mean quite young, 45 to 64. That's sounding younger and younger every day to me. But that, and then a few seniors, and then it looks like maybe a teenager or two there. So that was the age range. Now for gender, more females than males. We see that generally across our network. It tends to skew female in overall, and it did here as well. And then race was majority white, and then for ethnicity of that group, over just slightly over half was Hispanic or Latino. So that was interesting data there. And then as far as the resolution rates and the acceptance rates, they were quite high for this pilot, and that's what we like to see. So 96% of the time when the partners in this pilot sent a referral over to Feonix accepted it and did it in a timely way. And then they resolved 91% of those cases and provided the transportation needed. And so that is a real success story. And we appreciate the hard work by all of these partners. And that's what I have for you.
Well, thank you so much, Kathleen. Appreciate that feedback and all the hard work. And I know Jack is joining us. She is our dispatcher here at Feonix, or the lead dispatcher and dispatch manager. And she was amazing. She is kind of the main person at Feonix who manned the Unite Us platform when those requests came in and saw that happening. And so huge shout out to Jack and her team for all the hard work that happened to make this possible. So thank you. And thank you, Kathleen, for the opportunity to use the Unite Us platform as part of the project. All right. So when we talk about ROI, right, this is what everybody wants to know. What was your return on investment? We looked at two key dimensions. The first was the health system ROI, and the second was the taxpayer ROI, right? A lot of times people are saying, why should we invest our taxpayer money in this? So when we look at health systems ROI, we saw a little bit north of $1 million. And I'll break this down in the next two slides. And then from the taxpayer ROI, it was between $715,000 and $815,000. And this project, we spent the whole grant, we spent roughly $500,000 on all 3 years of the project, but that included a lot of other things that we also did. So we also did education and outreach. Belinda led a lot of that incredible work. We also did a lot of community engagement as part of kind of just understanding what the challenges were and getting things set up. So all in, we saw a pretty high return on investment. So from a health systems perspective, when you look at national models of this population, and as well as you look at regional data, of those 560 clients that we solved using those research models, we would say 140 visits roughly were avoided to the ER. These are folks who got to treatment, to regular care, primary care. They weren't using the ER as an urgent care. They were not overdosing and using the ER or so on and so forth. So of using national model data, 140 visits. And if you take that times $2,700,000 or $2,700 a visit, you're looking at $380,000, almost paid for the project just in ER visits avoided. Next is hospital admissions. These are folks who overdosed and went to the ER and then ended up in the hospital for a stay. 56 admissions, roughly $14,000 a stay. These are really, really conservative numbers. Fully appreciate your average ER visit many times is higher than this, or your average hospital admission is much higher than this, but we wanted to use really conservative numbers when we put this together. So almost $790,000 just in avoided hospital admissions. When we looked at kept appointments, and this is where Belinda and Amy, we talked about what's the average, revenue back to the clinic when you're providing these trips or these appointments and they don't go unmet, or patients get seen. On average, there's $125 for those appointments or those visits. And so just that was $75,000 that was able to be kept and saved for the health systems. And so total for this project in the 2.5 years we were providing rides, $1.25 million. And then we look at taxpayer ROI, right? Especially trying to understand why would we invest more taxpayer dollars in this program or in these kinds of programs. From Medicaid and Medicare, avoided, between the ER and the hospitalization, average cost $2,600. You're looking again, $500,000 to $600,000 just in not having those ER visits or those appointments missed. For incarceration, this was a huge need that we saw, that court appointments was almost 11% of the trips were folks getting to and from their probation officer, court hearings, so on and so forth. Based upon some of the national modeling we did with some of the research that's out there, figures are that we avoided roughly 1,500 days in jail or days of incarceration based on serving 560 clients in this population base. And again, this is a low number. And then the average cost, again, this is using Texas data from the State Justice and Parole Board, publicly owned jails, roughly $78 a day. Roughly comes to $116,000. So we saved our justice system $116,000. And we talk about foster care. These are children who are able to stay in the home with their family, with a parent, with a guardian that is somebody that is close to them. Saying these children are able to not go into that system with foster care, again, using national data, around $27 a day based upon research, looking at $98,000 of taxpayer money saved not paying for foster care. So overall taxpayer ROI, you're looking at $750,000 to $815,000 that we were able to kind of say this program not only paid for itself, it gave resources back to the community. So for every dollar that was invested in healthcare transportation for the SUD OUDs, patients who were in this program, $3 to $4 in taxpayer savings, health, justice, foster care, hundreds of thousands of dollars in health system cost avoidance. And then long-term, this means stronger families, better child outcomes, safer communities, and economic mobility. So overall, literally everybody wins. And so when we talk about what's next, okay, this is great. We learned a lot. We did a lot of really cool things. We have a lot to build on. What are we going to do next? And so one of the wonderful opportunities that we had was to evolve the technology from kind of that original screen that you saw. We received a grant from the Michigan Department of Transportation to build a platform that enables an app integration, a computer platform to put all the transportation options together and provide a mobility wallet without having to have kind of this third person, but also enables if somebody wants to book a public transit ride, if somebody needs to book a specialty transportation, if somebody books a volunteer, somebody books an Uber, all that can be done from one single portal and one single pocket of funding. So here you see on the screen, we have our technology called Catch a Ride. It's in the App Store. Anybody can download it and check it out, but there's a similar to any kind of ride scheduling platform, you put the pickup date and the drop-off date and time, and then it will show which transportation options are available. In this case, we're selecting door-to-door. They're putting in what kind of mobility assistance needs. Do they need a wheelchair, a walker? Do they have a service animal? All of those things will depend on what kind of transportation options are available or provided. And then from there, you can add any notes. You can add the trip purpose for tracking and recording and grant purposes. And then those return ride can be requested at the same time. And then from there, here in a second, you're going to see it's going to show your trip options, and then you can pay using a mobility wallet. This program and this technology has been expanded in not only into Michigan, Wisconsin, Tennessee, and then here recently also into South Carolina. And so here's an example of the technology in Tennessee that we're just piloting and deploying, trying to get somebody to and from work, right? And they're going into the platform, they're using the app, they're saying, okay, this is my pickup and drop off using our micro transit service. They're saying, I'm going to pay with my mobility wallet. In this case, you can see a sponsor or what it looked like. So this could be any organization that is sponsoring a mobility wallet. And then from there, all that conversation around, is a trip confirmed? What time is it arriving? All of those details are available in the app. And so there's much more information that goes into the platform and the technology through that. So mobility as a service in Feonix's world really means any mobility provider that is available in the community is able to receive and provide rides to support community partners. We have done this again across the United States. Here's an example of a mobility wallet that we deployed in Michigan around perinatal and infant health. We have public transit, we have Uber, we have the Wave, which is a rural public transit agency. We have a non-emergency medical transportation, People's Express and Gemini and Loving Touch. And so the patient, when they go to look in their app, can book from any of these transportation options and see the trip service. Here's another example with United Way, where they said, okay, we want to help get folks to and from work. And they're putting in information for the bus. And that's the only type of option they're giving through their mobility wallet. So you can customize and tailor that. There's a computer portal that has all this detail in it, and I'll send out a link to that with the slides and everything afterwards. But we got really incredible data that pulls in from that we can access in real time, where the trips are happening, when, how many new users, average trip cost. And now we're working on pulling all of that data into a national scorecard and national database. So not only can we say, here's the ROI in the Coastal Bend, but we can say, here's the ROI across the United States. Here's how many rides to SUD treatment and support that we provided nationally all at the same time. And so for next steps, we're identifying additional operational funding in the Coastal Bend to reopen the services. The grant has ended, and we're currently seeking sponsors and partners and collaborators and funders. We're also exploring opportunities to bring the transportation prescription to new communities, other healthcare partners, other clinical needs. We had a NIH grant for $12 million to bring this program to fruition. Unfortunately, that did not meet the priorities of the current administration, so that ended. But we are still actively looking for partners on that. And we want to identify research funding to further quantify impact based on patient pre and post data. This program was really focused on operationalizing a model. And now that we know the model works and how to operationalize it, we said, now we need that research partner and that research funding to really look and say, not just based on national models, but based on the patients who are exactly in this program. This is what the return was. We also want to work with policymakers to consider utilization of NEMA at other funding sources and other trip purposes. And then we'd love to explore integrating this technology into referral systems like Unite Us, or even in EHR systems like Epic, to save healthcare partners or other partners from like going into another platform to request that trip. So one of our North Stars. So with that, if you haven't already, please enter your questions or your comments, or if you are streaming on Facebook or LinkedIn, enter your comments in the portal, and we are going to bring everybody all back up here for audience Q&A with the time that we have left. So I know there's a few that have joined here. Everybody's going to come back on stage, and we would love to answer your questions. Ta-da. All right, so we've got Sean has one to kick it off, and they asked Belinda, did you experience a large number of cancellations or rescheduling when you scheduled a month in advance?
It really depended on the client themselves. I mean, for some, it was kind of wonky at times. What helped a lot, what I would meet with them if I saw that they had a no-show or two, just giving them a call and asking them, or do you really need the service? Is it, to see if there was further barriers. And then so figuring kind of that out, and then kind of putting them back on week by week until I saw that they were utilizing the services the way we wanted them to, and then I would take them back to the month. A lot of times for a lot of our clients, because they're, that does deal a lot with substance use disorder, it's hard for them to stick to something, right? So they have to see themselves that they have that self-efficacy to be able to do it, and to do it consistently. And so that helps. The chats, the small chats, and the reaching out really helped with that.
Awesome. Thank you so much, Belinda, for sharing. Jana asked or mentioned seclusion during COVID seems to continue, with some people still ordering everything to be delivered. I think that's a question that we see in rural areas. A lot of times delivery services are hard to come by. And so delivery service is calling up your children or your neighbor, or you're saying, hey, can you drop that off? Or hey, can you bring that by? But I think that's one of the huge things, is there are still a lot of folks who do not feel safe in outdoor settings, or are avoiding putting themselves in those situations. Absolutely. We had another question from Jessica, and she's asking, is there currently any funding in Jackson County, Michigan? And if so, where else are people supposed to go to specifically ask for the prescription? Is it pretty much anywhere? So great question. So Jessica, we do have a program in Jackson. We currently do not have funding for SUD, OUD prescriptions. We have had some conversations with some of the managed care organizations around bringing this to other treatment populations, or having it be a covered service. Would love to have that conversation with any of the MCOs that you've worked with, or that you believe would be interested in bringing this forward. I think there's definitely a lot of potential when we think about how do you address NEMT, or how do you expand NEMT, especially for areas where they're very expensive patient populations. This is a great return on investment. Okay, any other questions that have come in? Come on, don't be shy, everybody. I know we had a really good presentation, but please don't hesitate to ask. While we're kind of waiting, what advice would folks here on the line have that you would give to another community who's thinking about launching a transportation prescription program or something like this? Like, what advice would you have for those partners on the line?
I would say get support from elected officials. Find that diamond in the rough that's going to push that narrative of how important that these transportation programs are in these rural communities, and someone that's going to talk about it at every speaking event that they go to, and talk to agencies that could help, talk to agencies that could help us accomplish what it is that we're trying to accomplish, and rather than just patting us on the back and telling us this, you're doing a great job. Well, that's great, but I need for you to connect me with the people that I need to be connected with in order for me to for my agency to be successful and to ensure the success of the community that we're trying to serve.
Yeah, I love that.
And I would add to that, in doing so, really have those stories. I think the personal stories, the data as well. And of course, I love data. That's what what we're about. But backing up that data with personal stories, and then talking to the officials, and then and getting buy-in from other partners as well. I think that's huge.
Absolutely. Amy, any advice?
Part of my thought is that there's like two factors here, because when an agency misses out on a possible contact with an individual, they're losing funding also. And then the other piece of that is how promoting how having that transportation and being able to have access to those resources that are out there could in turn drive down the costs of healthcare or the jail system. So I think that that's something to consider also, how it can help with driving down costs of other agencies or individuals that are, like I said, in the jail system, or it could drive down those costs.
Yeah, absolutely. And I think that this grant and the research results from it, or the results from the clients and the patients that we have, even just using national modeling based upon other research that's been done in this area, is really significant. And I think to be able to look at that and say that we're saving literally almost $2 million just over the course of this program on this small subset of patients is incredible. And to be able to, make taxpayer dollars go further, right? All the resources that we talked about are foster care, incarceration, jail systems, healthcare systems, public funded, all of that. And to be able to make our dollars go further, and most importantly, healthier families and healthier individuals. I mean, it's such a win for everybody. All right. Well, I have not seen any other questions come in. We must have answered all of them during the presentation, but thank you so much, Amy, Belinda, Kathleen, for joining us. Thank you to all of our listeners. We will be sharing the slides afterwards. You will be able to watch this and send this link to all your friends. Thank you so much for joining us. It was so good to see you, Jana and Kim and John and everybody on the line who was here from the very beginning when we started this program. Sincerely, thank you. And a special support thank you to HRSA for funding this project and making this even possible. I know we gave the disclaimer at the beginning, but thank you so much for your investment in this program and this project in the community. So thank you, everybody. I hope you have a wonderful afternoon.